It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back to the show and thanks for listening. I'm going to be talking about the TENS unit today. It's been a hot topic for the pain boards and was recently asked. Well, it's asked every year on the test. And this is probably the first podcast I ever did regarding it. I think I have some questions on the pain exam board prep at the nrappain.org website. Just go to painexam.com or nrappain.org for board prep, and you'll see the question bank, virtual pain fellowship, and more. We also have monthly ultrasound courses, and I'm doing a course in November in Florida near Hollywood or Fort Lauderdale. I'm about to secure the venue, as well as a couple of courses in Detroit, ultrasound-guided regional anesthesia and chronic pain courses, and of course in New York. And I have some instructors helping me out, so you'll get different perspectives, and hopefully everybody will get what they came for. So just go to nrappain.org and just click on the CME calendar. It will give you the links to sign up and see all the dates. In addition, we have the New York, New Jersey Pain Conference in November, hosted by my good friend Sudhir Dewan, as well as ISPN, which I'll be teaching ultrasound at next week in London, so I'm pretty excited for that. Anyway, let's talk about TENS, because they will definitely ask you about this on the pain boards. So TENS stands for Transcutaneous Electrical Nerve Stimulation, and it's used to treat acute and chronic pain condition. It was first really published, the data was published for over 50 years ago. And over the last 2 decades, there's a better understanding of the mechanisms underlying TENS efficacy. And there's development of the adequate dose, which we'll get into, and proven to some proof that there is some benefit. So the summary that I'm going to go over includes trials with pain as the primary outcome. Outcomes were rated as positive, negative, undecided, or equivalent to other interventions. And they're going to the notes in the links in the show notes, so you guys could check it out yourself. And basically, the parameters of pulse frequency and pulse intensity are adjustable with the TENS unit, and they can be related to the efficacy. TENS can be applied with low frequencies, less than 10 hertz, or high frequencies over 100 hertz, or mixed frequencies, where you can have a little both the high and low. Frequencies of stimulation result in unique mechanisms of action for TENS, and they outline it here. They summarize mechanisms of actions and factors that influence TENS efficacy, and described and critique the use of TENS for various pain conditions. So the mechanisms underlying the analgesia with TENS is that the TENS activates inhibitory mechanisms. It reduces central excitability primarily in the CNS and consequently reduces pain. TENS activates large afferent fibers in the periphery that send input to the central nervous system. By the way, this is on the boards. This could be on the boards, and has been asked which fibers are activated. Anyway, this signaling of this activation of the large afferent fibers in turn activates descending inhibitory systems that reduce hyperalgesia. Now, the analgesic effects of the TENS is mediated through multiple receptors, but specific receptors utilized depend on TENS frequency. Early studies show that high-frequency TENS over 50 hertz increases the concentration of B endorphins and methionine and enkephalin in the CSF, and that low TENS, less than 10 frequency analgesia, was prevented by blockade of the opiate receptors with naloxone. TENS produces analgesia that is prevented by blockade of opiate receptors in the rostral ventromedial medulla or spinal cord in a frequency-dependent manner. So note, the high-frequency TENS analgesia is blocked by the delta receptor antagonist, and the low frequency is blocked by mu receptor antagonist in the spinal cord and RVM, or rostroventral medial cortex. The opioid-mediated analgesia produced by low-frequency and high-frequency TENS has been confirmed in human subjects. Additionally, blockade of the muscarinic M1 and M3 receptors and GABA A receptors in the spinal cord reduces both low-frequency and high-frequency TENS analgesia. So these are like all involved. Cannabinoid receptors as well, and you need to look at this. It's really in depth. In addition, TENS reduces central excitability. It directly reduces the activity of nociceptive dorsal horn neurons in uninjured animals and sensitization of the dorsal horn in injured animals. There are peripheral mechanisms. Very few studies show this, but high-frequency TENS reduces tissue injury, increases in substance P in the DRG neurons. Blockade of peripheral opioid receptors prevents the analgesia produced by the low and high-frequency TENS. Blockade of the CB1 receptors prevents production of the analgesia by the high-frequency and low-frequency TENS. So TENS alters excitability of peripheral nociceptors to reduce afferent input to the central nervous system. There are other factors that affect TENS efficacy, and it could be the timing of the dosing, the frequency of use. There's a lot listed here. You can go check it out. They cite various studies. Now, as far as TENS for chronic pain, a Cochrane review for TENS and chronic pain included systematic reviews for chronic pain, excluding headache and migraines. It included 9 systematic reviews with 51 clinical trials comparing active TENS to sham TENS with a pool of 2,895 patients. Authors looked at adverse events as a primary outcome. However, they were unable due to inconsistent reporting of adverse events. In the systematic review, the quality of the clinical trials was rated as very low due to the risk of bias, small sample size, and limitations in methodology. Ultimately, the evidence was determined to be uncertain for TENS efficacy. However, this factor is potentially misleading, the author writes, because adequate TENS dose was not mentioned as a metric for inclusion of the trials. The comparisons of interest included in the review include TENS versus usual care or no treatment weighting as the control, TENS versus sham TENS, and TENS versus active intervention alone, and the different types of active TENS parameters, which adds the uncertainty of the finding, meaning I guess they don't really know. So despite all this, the author basically is concluding that TENS is cheap but has uncertain efficacy. It's low risk. There is a better understanding of the mechanisms of action of TENS now, but they call for more studies because they're really not sure if it works for the majority of these problems. I know it's kind of funny that we're not sure if the thing works, but it's around, it's on the boards, it's a big thing that patients sometimes ask for. PTs love this, so I don't know what to tell you. To summarize, make it simple for you guys. TENS is non-invasive, inexpensive, self-administered technique to relieve pain. Few side effects, and you could titrate it as you see fit. It includes the gamut of TENS techniques includes regular TENS device with the pads, stickers, acupuncture-like TENS, or acupuncture-like TENS. The TENS activates large diameter noxious afferent A beta to reduce nociceptor cell activity and sensitization as a segmental level in the central nervous system. A beta will be tested on the boards. Pain relief for controversial TENS is rapid in onset and offset and is maximal when the patient experiences a strong but non-painful paresthesia beneath the electrodes. Therefore, patients may need to administer TENS throughout the day. Clinical experience suggests TENS may be beneficial as an adjunct to pharmacotherapy for acute pain, although systemic reviews are conflicting, as I mentioned earlier, and we need to find out more about this therapy. However, for the boards, just remember A beta, large diameter, non-noxious afferents. These are what gets activated selectively, okay? That's the most important thing to take away from this little talk. Once again, hope to see you online and offline. I'd like to see you at my courses if you're interested in learning regional anesthesia or interventional pain. I do private coaching as well, and you could shadow me for a day. So If you're interested, shoot me an email, reply to any of my newsletters. If you're not on the newsletter, just go to nrappain.org, sign up. Also, we have that board prep, regenerative medicine, interventional pain, and regional anesthesia chat forum on the nrappain.org. So if you sign up to nrappain.org, you get a free access to the NRAP community where we discuss neuromodulation, regional anesthesia, and pain. And thanks for listening. Hope you enjoyed the show. Take care.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.